what about transformation of Waldenstrom's? I understand that transformation is exceedingly rare. However, I am familiar with several WM patients who have experienced transformation. What do we know about this change today?
Well, I think we know from now a number of series that have come out from different institutions. Our institution, the French group, as well as the MD Anderson group, who have now looked at this, is that we do see an increased risk of transformation, but it's associated with certain drug classes, the most common of which now are fludarabine and cladribine. And so when one looks at the data, it's about 10% risk of transformation with those drugs. So it's really not that uncommon. And when you look at patients who have not received these drugs, who either are untreated or treated with other agents, their risk is much, much lower. So seeing transformation de novo, meaning without somebody ever having been treated, is exceedingly rare. And seeing transformation with other treatments, the nucleoside analogs, at least in our series and those of the French, has not really resulted in a signal for increased transformation.
Can you comment on exactly what transformation means, you know, in these studies? Because I think some people confuse, for example, CNS involvement as transformation.
Yeah, so I think that's a very good point, Rafat, is what exactly constitutes transformation. And even so, you know, we use this term a little bit broadly because, you know, what we see typically is a patient coming in with a more aggressive lymphoma. It's usually diffuse large B-cell lymphoma. And the one thing that we don't have definitive links on is, did that aggressive cancer come out of the clone that was previously a Waldenstrom's clone, or is this a new primary that is a diffuse large B-cell lymphoma? So I think there's a little bit of room there in terms of being able to nitpick on the term transformation. But when we use the word in aggregate, what it means is a patient who had a low-grade lymphoma now presents with a high-grade lymphoma. And for those of you who may not be knowledgeable, high-grade lymphomas typically have a very, you know, aggressive course. These cells multiply exceedingly quick. They don't have the kind of month to years kind of growth pattern that the low-grade lymphomas like Waldenstrom's do. But their growth can be measured in days to weeks. And if you're not treated for the aggressive lymphoma, you know, the patient will succumb. Now, there is some good news with this, and this came out of the study that we did and published in JCO 2 years ago. And that is that for those patients who were unfortunate and transformed, their survival didn't differ from those individuals that were not transformed. And the reason for that was, based on those study results, that treatment has gotten really good for transformation. In those cases, patients who got CHOP Rituxan, you know, were cured of their transformed or aggressive lymphoma. And that tends to be what we see in de novo transformed or de novo aggressive lymphomas. And it's because therapy has really improved that we're able to manage these patients much better. That still doesn't give us the license, I think, in a broad way to use agents that may increase risk of transformation. And that's why we have to weigh, I think, very carefully, you know, these agents, the nucleoside analogs, the fludarabine, and other options.
Steve, in the same line, do you think that we will see more transformation in the years ahead because Waldenstrom's patients are living longer nowadays?
Well, I have to tell you, Bob, in those studies that we did, I mean, we had pretty good follow-up. And it's not to say that, you know, more follow-up may not produce a different signal. But seeing, you know, de novo transformation, even with long-term follow-up in this disease, is a little unusual. But only time will tell.
Is there any reason to treat WM while asymptomatic, that is, smoldering Waldenstrom's macroglobulinemia?
No. I mean, I think at this time it's premature. It's not like, you know, having a lump in the breast, and if you don't take it out, the patient is going to be in big trouble. You know, this disease is widespread, and if you get rid of all the Waldenstrom cells, you have to give aggressive therapy, and we don't know if aggressive therapy is going to change the course of the disease. And so really, it's not indicated. I mean, these patients can go on for years and live their normal life and die from something else.
Yeah. And in 2002, I'll just remind the audience that Dr. Kyle, along with Dr. LeBlanc, shared the consensus panel on recommendations for when to treat and when not to treat. And if the patient is asymptomatic and their counts are relatively good, then that patient should be followed. And these guidelines, I think, were very important, and we really owe a great deal of thanks to Dr. Kyle and the other members of this committee, because you could take the same patient and have presented them before those consensus guidelines to two different physicians. And, one might have treated that patient aggressively, because they had the Waldenstrom's diagnosis and even transplanted them. Whereas, another physician would say watch and wait is the norm. And so I think we owe Dr. Kyle a great deal of thanks for putting those guidelines forward to us.
Several people have spoken of being cured. Is this possible?
If this was asked of me, I think a decade ago, I probably would have had a different politically correct answer for you. But what we're seeing today with many of these new drugs is that patients are going into remissions, even complete remissions, even deep remissions for very long periods of time. And where do you make the cutoff as to where a patient is cured or not? I mean, I have now one patient who's 10 years out in a complete remission, who was treated on our fludarabine Rituxan study, and I know she's known to many of you, who remains disease-free. And I just want to point out that a very interesting and very clever statement that I once heard is, that cure represents, the scenario where, somebody dies of something unrelated to their disease. And if old age is that answer, then it's fine.
You're telling us, Steve, that no one gets out of this world alive.
Or paying taxes, for that matter.
Okay. We wax a little philosophical here. Is smoldering WM still cancer?
I mean, I think the answer has to be yes, because you have a malignant condition, and you have an expansion of a cell population that's still alive, and in some cases slowly growing. Now, the one thing that I would say that if I look back historically on this disease, that has impressed me is how much variability there exists in smoldering patients, much like in myeloma, but perhaps even more so with Waldenstrom's. To have patients who come in with lots of disease, half their bone marrow occupied by Waldenstrom's cells, IgM levels in the 5,000, and yet, for some reason, these patients don't progress. They get diagnosed, they come to you, you follow them for the next 10 years, you recommend no therapy and watch and wait. And these are individuals that don't progress. So there may be other events that come along that add to their burden. Infection, perhaps being one of the considerations that we can perhaps bring up or speculate on. But something triggers that disease to move ahead. So there are a lot of people, and much like I think Bob has taught us over the years with myeloma, that you need to be able to delineate these patients, because treating these patients who are asymptomatic and whose disease is stable is really, unwarranted. And I owe Bob a great deal of thanks, because that his teachings in myeloma allowed us to observe these patients. And now we see 10, 12, 15 years later coming back and still are stable. So I think the best thing you can do for these patients is continue to watch them.